Welcome back. It's my pleasure now to present a case on the Rick-A-Nator. In this one, I'm going to show you how to reline the Rick-A-Nator as well. My next patient is a little boy, 11 years old, with a deep overbite and headaches. I've mentioned many times in these videos that deep overbites are very indicative of headache problems. Here's a little boy, age 11, with headaches. And unless someone investigates this problem and looks at the temporomandibular joint, then they're not going to be able to find out the reason for the headaches. So the overbite is 6 millimeters. You can see the deep overbite, 6 millimeters on both sides, and he's got a class 2 molar relationship. So you can see the molar relationship's class 2, deep overbite, again, very vertical upper incisors. Now this is ideal for a Rick-A-Nator. In this video, I'm going to show you how to reline the Rick-A-Nator, which is very, very important, and show you the materials we use to do it. Step by step, how to reline a Rick-A-Nator and treat him. Let's look at his profile. His profile is very retrognathic. His lower jaw is definitely behind his upper jaw. He's got a large submental crease right here. You can see the large submental crease right there. And he's overclosed vertically. So again, what you want to do for this case is not intrude the incisors. When you have a patient who's overclosed vertically, large submental crease, mandible back, you do not want to intrude the incisors. So all intrusion mechanics is out. You want to extrude the posterior teeth. You want to increase the posterior vertical dimension. So this is another case where, remember, the best way to increase the posterior vertical dimension when you've got deciduous teeth is to add composite buildups to the existing lower primary molars. You can see there's a close-up of his profile. And you can see from anterior nasal spine, which is just below the nose, to just below the chin, you can see that's very short lower face height. And the giveaway is that large submental crease right here underneath the lower lip. That is not attractive. That's not an attractive looking profile. And he's overclosed vertically. So we want to restore that profile. Wait till you see at the end the tremendous difference we made when we opened the vertical and advanced this mandible a little bit. Remember, he's got a class 2 molar relationship. He's got an overjet of 4 millimeters here. So he's got an overbite of 6. He's got an overjet of 4. And what we want to do, and he's got an underdeveloped mandible, so we want to bring that forward. We certainly don't want to take the upper teeth and move them back. So your diagnosis can be made on the cephalometric film, but can also be made looking at the patient's profile. When you look at the patient's profile and you see they're overclosed vertically, you want to increase the vertical. When you look at the patient's profile and you see the mandible is back with a large submental crease here under the lower lip, you need to advance the mandible. I mean, your diagnosis can be made looking at his profile. Whatever makes his face look better will also make him healthier. That's the interesting thing. Whatever is good for the face is usually also good for the health of the temporomandibular joint. So when you increase the vertical, you help move the condyle down and forward, decompress the joint, help the temporomandibular joint. When you bring the mandible forward, you move the condyles down and forward, decompress the temporomandibular joint. So his headaches are going to go away when we reposition his jaw to the correct position. It's not in the correct position now. He's got an overjet of 4. He's got an overbite of 6 millimeters. When do you want to treat him? You want to tell that mother, come back when you're 13, all your permanent teeth are up? I'm afraid that that's the answer he gets if they go to some offices. And it's not really the general dentist's fault, because the general dentists have not been trained in dental school in most cases to be able to diagnose or treat these cases. And in some orthodontic programs, they don't stress early treatment. I must admit, though, it's getting better and better, because on the American Association of Orthodontists website, for about the last 6 or 7 years, they've been recommending that children be screened by age 7. And that is a positive. And more orthodontists are definitely getting into treating these children. So your options are find an orthodontist who can treat these kids, who believes in early treatment, if you don't want to do orthodontics, or probably because you're watching this video, you want to do orthodontics, then you should treat these children yourself. But someone has to treat them. To leave these cases untreated, to me, is supervised neglect. This guy has headaches, he's got a malocclusion, he should be treated now. He needs to be treated now, not wait. And it's an easy treatment. This is a great case for a Rick-A-Nator. There's the Rick-A-Nator. There's the Rick-A-Nator in the model. When it comes from the lab, it either can have the anterior bite plate, which is made of a processed acrylic, and it can either have the incisal ramp already made on there, or the dentist can add the incisal ramp. So I can show you how you take impressions if you want to have the lab make it, or how you do it yourself. Many times I've found when it comes back from the lab, it's not quite right. So therefore, you need to know the technique to reline it. So I'm going to go through the technique with you now. Remember how we get to this stage, okay? We place separators right here, place separators between the second bicuspid and the first molar. Separator there and a separator there. Bring the patient back in a week. Take out the two separators. Fit 2 molar bands. Now remember, when you fit the bands, it's better, because if the lab fits the bands and they scrape the model, when that comes back from the lab, it won't fit. If they scrape the model, the bands will be too tight and won't go in the teeth. Or if they make the bands too loose, then the Rick-A-Nator may not stay in. You may get secondary decay due to decalcification, leakage around the bands. So you don't want that. You need to fit your own bands. So you bring the patient back in a week, fit the 2 molar bands, take them off the patient's teeth, take an upper model, pour it up in Yellowstone, take a lower model, pour it up in Yellowstone, send the 2 models plus the 2 bands separately to the lab, and they'll send you back this. Okay, so this is an anterior bite plate, which goes behind, remember, the central and lateral incisors. Now this is a little longer. It's kind of contacting the primary cuspid, so we'll have to grind that off and adjust that. And we've got an 050 wire, 050 stainless steel wire, nice strong wire, and we've got an omega loop, just mesial to the molar, and then it's soldered to the lingual of the molar bands. So it's a one-piece appliance, it's cemented in. Now sometimes, if you've got a good patient, you can cement it for 3 months, and then the patient, if they're a good cooperator, you can make that removable. So the patient can take it out, clean it, put it back in. But for a 10-year-old boy, I think you should make it fixed, because he's probably not going to be as cooperative as some of the 8-year-old girls we deal with. So it's cemented in. But again, the decision is made by the mother. We talk to the mother and see how cooperative he is. If he's not that cooperative, then just cement it in. He gets used to it. It's better for him. There's the Rick-A-Nator off the model. You can see it's just an anterior bite plate in the front, behind the upper central and lateral incisors, the 050 stainless steel wire, omega loop, and 2 molar bands. Very simple little appliance. And there it is. We try it in. So try it in, see how it fits, and you can see that it's a little long in this area. So we take a red marker and we mark the acrylic right here. Mark the acrylic and then just trim it off, because you only want it to contact the 2 central and lateral incisors on the lingual, not the primary cuspids. We try to make it as small as possible to increase the chances of the patient cooperating and liking the appliance. So we take it off. We use the band removing pliers. So take band removing pliers. You need to buy those. And take the bands off. If the Rick-A-Nator fits properly, you will not be able to take it off with your fingers. I mean, if you can put it on with your fingers and take it off with your fingers, the appliance is too loose. You usually have to use a band pusher or a band seater, and you have to remove it with the band removing pliers. It should fit tightly. Okay, so we take it off with the band removing pliers. We've already marked with the red marker there. You can see where it needs to be trimmed. We take it off and we take out an acrylic burr. We have a little Dremel tool, which we have in each treatment room, and we just have that for removing acrylic. And that's the easiest way to do it. So we just take the little Dremel with the acrylic burr and just trim that off. So you can see we're trimming it off right there. This is the setup for relining the Rick-A-Nator. Now, as I say, the lab can sometimes put that incisal ramp on for you, but sometimes it comes back from the lab and it's not what you want. So some dentists will just reline them all, and some dentists will reline the lab to put the incisal ramp on. But you need to put an incisal ramp on there. You can't have the patient biting on this anterior bite plate. Patient bites on the anterior bite plate, they'll have no definite bite. They'll slide all over the place and be very, very bad for them. You know how good it feels to bite on your teeth. Well, if you put an anterior bite plate on there and don't put an incisal ramp on there, they won't be able to bite correctly. So here you can see we've trimmed it off nicely with our acrylic burrs right on both sides. And here's the setup for relining with TRIAD. We use the TRIAD TRANSHEET colorless, and I'll show you the number in a minute. We also use the TRIAD VLC bonding agent, which is like our sealant or activator. We have our bonding light, our curing light, and we also have our Dremel tool here. So that's basically all you need to reline the Rick-A-Nator ramp. Remember, the acrylic only contacts the central and laterals on the lingual. But you can't have the patient bite on that, as I mentioned. You must put the ramp so they can bite in one specific spot. First thing you do then is you roughen up the surface of the anterior bite plate. Roughen up the surface of the acrylic bird. You can see how it's now not shiny anymore. It's all roughened up. Okay, then you're going to take your TRIAD VLC bonding agent, okay, and you're going to add a very thin layer to the anterior bite plate. Sometimes you might want to take a little bit of a cotton sponge and just wipe it off gently, because you just need a very, very thin layer. If it's very thick, then what will happen is the TRIAD will not stick as well. So then once you have a nice thin layer here, and you can see we've got a little bit of a sponge here, and we're sponging that off, and then we're using our curing light just to bond that. So we always put our protective glasses on, and we cure that. The patients get a big kick out of my yellow glasses. And then you're going to add your TRIAD TRANSHEET colorless. Okay, and the number there is 001201C. That's what you want to order. And it comes in a black paper. You want to keep it always covered up, because light will cause that to set. So that's why it comes in this special black package. So take out a little bit and just form it in the shape of a ramp. So just form a little bit in the shape of a ramp. And then you're going to put that on the anterior bite plate that you've already added the sealant. Okay? So just add that on there. And you can see we're just forming it on there. Nice little bit. And there you can see it's nicely formed. We form a ramp. And we don't want it too long. The longer the ramp, the less likely the patient is to tolerate the appliance. We'd like it maybe 3 millimeters long. That's all. So we have it in there, and we just put don't use excess material. You have a close look at that and see the amount of material we put on there. That's not a lot of excess material. So just put a nice little layer on there first. Then you put it in the patient's mouth. Again, you're going to have to probably use your band pusher or your band seater to put it in there. You won't be able to put it with just finger pressure. It'll be too light. The bands have to fit more tightly than that. So have the patient bite like that, and then you line up the midlines. You want to line up your skeletal midlines. You don't want the mandible to shift to the right or to the left. If it shifts to the right, your condyle may go up and back too far on this side. If you move it this side, the condyle may go back on this side. So you want to bring the mandible straight forward. Now you're lining up skeletal midlines here, not dental midlines. So if your dental midlines are off and your skeletal midlines are on, then you leave your dental midlines off and just bring the jaw straight forward. Sometimes what I'll do, and it doesn't look like we've done it here, is I will put red marks on the teeth. So just look where my pointer is here, and look at that line on the teeth. Look at the line there, and look at the line there. We use the same wax marker, the red wax marker that we showed you earlier, to mark the anterior bite plate. Just use that to line up your skeletal midline. Then you have the patient actually look at a mirror. So you're holding up a mirror like this, and the patient bites forward. You have to look in a mirror. They'd have to look in a mirror. They can't see where to go. So they would bite their teeth forward, and we want to, if the skeletal midlines are on and the dental midlines are on, like it looks like in this case, then that's easy. Just tell them to line up the cracks between their two front teeth. The lines between the two front teeth. Just tell them to line that up. And we usually like them to have them bite with a 1 millimeter overjet, 1 millimeter overbite. In this photo, you can see they're biting kind of end to end. So I would have the patient just bite slowly back. So there's a 1 millimeter overjet, 1 millimeter overbite. So here's the patient with a 6 millimeter overbite and a 4 millimeter overjet. Here's the patient now with end to end. So we're going to have the patient just change now and just move the mandible a little bit back. They're here like this. I'll have the mandible slightly back with a 1 millimeter overjet, 1 millimeter overbite.